first thing is don't be scared of the word cancer.
One thing we should understand is a woman comes to you with a palpable lump. तो हमको पहली चीज उनको बतानी है कि 8 out of 10 times इसमें कैंसर नहीं होने वाला है.
He was the one who suggested कीमो के दिन भी कीमो लेके घर जाओ और 5 किलोमीटर वॉक करो हर दिन.
You don't need sympathy. Nobody needs sympathy. Many people dislike sympathy, but they require interaction as a normal person.
After that initial phase of, oh my God, my hair's gone, I was absolutely okay with it. You know, I said, okay, this is to hell with it. This is my new look. This is the way I am.
We have seen this fourth stage patients also leading a normal life.
If you have that will to live, you'll fight it. Welcome to the Hope and Healing series, episode 3. दोस्तों, पहले के एपिसोड्स में हमने जाना कि अर्ली डिटेक्शन और ट्रीटमेंट कैसे जिंदगी बचा सकता है. आज हम बात करेंगे उस सफर के बारे में जो डायग्नोसिस और ट्रीटमेंट के बाद शुरू होता है, लाइफ बियॉन्ड कैंसर. इस एपिसोड का फोकस है सर्वाइवरशिप, इमोशनल हेल्थ, फैमिली सपोर्ट और लॉन्ग टर्म केयर. हम समझेंगे कि कैसे पेशेंट्स और उनके परिवार मिलकर इस सफर को मैनेजेबल और होपफुल बना सकते हैं. इस इंपॉर्टेंट टॉपिक पर क्लैरिटी और गाइडेंस के लिए मेरे साथ हैं एक्सपर्ट्स और वॉरियर्स. डॉक्टर सुरेश अडवाणी, इनको कौन नहीं जानता है. डॉक्टर बोमन धाबर, इन्हें भी कौन नहीं जानता है. डॉक्टर मंदार नाडकर्नी, ही इज द बेस्ट, ही इज माय डॉक्टर. एंड हमारी वॉरियर डॉक्टर खुर्शीद मिस्त्री. थैंक यू सो मच आप यहाँ पर आए एंड आई होप वी हैव अ ग्रेट सेशन और लोगों को ये बहुत ज़्यादा इंफॉर्मेटिव लगे और बहुत हेल्प करे. चलिए शुरू करते हैं और समझते हैं कि सर्वाइवरशिप का मतलब क्या है और ट्रीटमेंट के बाद कौन से फॉलोअप चेक्स हर पेशेंट के लिए ज़रूरी होते हैं. सर, पहले आप बताइए. वी आर वेरी ग्लैड टू हैव यू इन दिस पैनल, Padma Bhushan and Padma Shri Dr. Suresh Advani. So glad to be here with you. Sir, I have a question. आपको अक्सर लोग फादर ऑफ ऑन्कोलॉजी भी बोलते हैं एंड मैं खुद आपके पास एडवाइस लेने के लिए आती हूँ. कल ही हमारी मुलाकात हुई है. मेरा सवाल आपसे है, what does life after breast cancer mean for someone who's been through it?
हमने देखा है कि all the patients, they want to live a normal life. Even after the breast cancer, they want to live. But I think one thing which bothers them is uncertainty about life.
जी.
Life is uncertain for everybody. But here, they become more conscious about it. And therefore, that uncertainty really plays a role in their life. And therefore, they become uncertain. Anything happens to them, they think of the disease. Even little bit headache or pain in the back, they become uncertain. So they get worried about because of that. And that's what really plays a difficult role for them. So slowly, as the knowledge and information they get from different patients, from the doctors who spend time with them, they slowly learn to look at the positive side of it. That what is positive is that you are going to live a good life, normal life, good quality life, and that's what they want, everybody. So I think it's a question of time that they change their perspective.
Yeah. Moving on, sir, thank you so much for this insight. Dr. Boman Dhabar. Sir, we are very fortunate to have you in this panel today. You're known for your compassionate care and cutting-edge approach to cancer treatment and very well known in Mumbai. What do you think is the most important follow-up checks after treatment completion?
There is nothing to substitute a history from the patient. You have to ask the patient what are the symptoms. Are there any persistent symptoms hai kya unke paas? Physical examination is also very important, I feel. Maybe the older generation people do physical examination, but physical examination is a part of the treatment, especially on the mastectomy side.
Ji.
Because that may not be picked up by anything but physical examination.
Especially on the mastectomy side.
Yeah,
where
mastectomy
everything has been removed.
So physically, Examination, I feel, is very important than that. Opposite side, yes, we do a mammography. Sabka mammography hota hai. Once in a year is what is recommended. Has to be done. Why we do opposite side mammography? Because if we catch that disease earlier, we can treat it. God forbid metastasis hai, to catching the disease 1 month earlier or 2 months later doesn't make a major difference. So, on local side, if there's a loco-regional recurrence, you can treat it very fast. So that is why this opposite side mammography is a must. If a patient, now what does the patient have is also very important. Genetic counseling. Suppose BRCA carrier hai. So you have to be patient, ask the history, family history kya hai, kya nahi, on follow-ups. And genetic counseling is also very important at that time. Whether they have done the test for genetic counseling, oophorectomy hua hai, kya hua hai. So all those discussions are a lot when they come for a follow-up, especially if it is not done, because there is a lot of resistance for a
to go for double mastectomy or oophorectomy.
Especially if they are a BRCA carrier. Then, as you know, 10% of the population are BRCA carriers or have a genetic inheritance. So, वो सब चीज important है. And of course, you have to look at the ovarian function, all those things also, if the patient is hormone positive disease. So there are a lot of things on follow-up. So follow-up is not just a 5 minutes job. It takes time. The patient comes to me. And many times, you know, mammography has been done and patient wants you to see the mammography film, which we are not supposed to, but we see the reports, obviously.
जी. Thank you, sir. ये सारी बातों के बाद हमें ये समझना है कि सर्जरी के प्रैक्टिकल एस्पेक्ट्स और नए एडवांसमेंट्स कैसे पेशेंट्स की रिकवरी और कॉन्फिडेंस को सपोर्ट करते हैं. We have with us Dr. Mandar Nadkarni. So he's my doctor as well. He's treated me. तो मैं आपसे ये सवाल, मुझे बड़ी खुशी हो रही है आपसे सवाल पूछते हुए. You are a very well-known and renowned oncosurgeon. And that's what makes this panel even more interesting and enriching. You've performed more than 8,000 breast surgeries, including mine. Patients from across the country visit you. When a woman presents with a breast lump, what is the pathway you approach before deciding on surgery?
So, one thing we should understand is a woman comes to you with a palpable lump or a lump that she has found. उनको अगर गांठ लगती है हाथ में, तो हमको पहली चीज उनको बतानी है, और जो हम हमेशा ऑल डॉक्टर्स बताते हैं कि 8 out of 10 टाइम्स इसमें कैंसर नहीं होने वाला है. Only 2 out of 10 times, if there is a lump, there is a risk of a cancer. So the main crux is we have to be able to identify those patients who are in those 2 and reassure the remaining 8 कि बाबा आपको कुछ नहीं है, चिंता नहीं करो, घर जाओ, ये गोली खाओ या कुछ भी और करने की जरूरत नहीं. But we can't afford to miss the 2. तो ये 2 जो पेशेंट्स हैं उनको आइडेंटिफाई करने के लिए हमारे पास एक सिंपल टेस्ट है, इसको हम कहते हैं ट्रिपल टेस्ट. ट्रिपल टेस्ट इंक्लूड्स अ गुड क्लिनिकल इवैल्यूएशन, एग्जामिन करना है और अपने माइंड में बिफोर यू अलाउ योर माइंड टू बी बायस्ड विद एनी इन्वेस्टिगेशंस डिसाइड करना है कि आपको क्या लगता है इसमें कैंसर है, नहीं है, क्या है. The next 2 investigations are going to be an adjunct to your clinical evaluation to assess by imaging, mammography, sonography, कि this also suggests is there a cancer or
no.
it suggests that it may not be a cancer and you may have overestimated maybe clinically. Whatever you feel clinically and on imaging, you keep in your mind, and then the only proof of
Biopsy.
whether a lump is a cancer or not is a biopsy. उसमें एक छोटी सी सुई लगा के टिश्यू निकाल के माइक्रोस्कोप के अंदर देखना होता है. मैं कितना भी कॉन्फिडेंट हूँ इसमें कैंसर है या सोनोलॉजिस्ट कॉन्फिडेंट है कैंसर है, द ओनली प्रूफ इज द बायोप्सी. द बेसिक पॉइंट ऑफ अ ट्रिपल टेस्ट इज अगर तीनों ये जो जजमेंट्स एक ही डायरेक्शन में पॉइंट करते हैं तो it is 100% accurate. If one of them goes in another direction, then you have to restart, go back to the drawing board and maybe add some imaging or repeat a biopsy or do something like that. This is as far as the diagnosis is concerned. So when you do a biopsy, you come to a diagnosis and now you know that this patient either has a cancer or not, and if she has a cancer, what are the drivers of the cancer? Estrogen receptor, progesterone receptor, HER2 receptor.
Yeah.
I won't go too much into details, but these are 3 critical things that we need to know, especially for stage 2 patients. Okay? The next step is to do a staging. We want to know ये बीमारी और कहीं है कि नहीं. The most common used technology is a PET CT scan where we do and we see के और body में है कि नहीं बीमारी. So एक तरफ biopsy और triple test हमको diagnosis देता है, स्कैनिंग हमको स्टेज देता है एंड देन द कॉम्बिनेशन ऑफ द टू करके हमको समझता है कौन से पेशेंट को सर्जरी करनी है पहले, कौन से पेशेंट को अर्ली स्टेज होते हुए भी, बिकॉज टुडे गाइडलाइंस हैव चेंज्ड दैट इन 2 different types of cancers, as you are aware, even if it is early, one has to start with chemotherapy with or without target or immuno, because that gives a better outcome. So ये investigations करने के बाद we get a wholesome idea of what you're dealing with, and इसके बाद में हम हमारी next step लेते हैं.
Okay. So इस मुश्किल सफर को पार करके आज हमारे बीच हैं डॉक्टर खुर्शीद. We welcome you here. Thank you so much for your time. And आप सच में हम सबके लिए बहुत बड़ी इंस्पिरेशन हैं. I've heard about your journey and I want people to know, which is why मैं आपसे कुछ सवाल पूछूंगी. प्लीज आप दिल खोल के जवाब दीजिएगा. So my question to you is, what was life like after treatment ended? Was it easy to move forward?
So I would say yes, for sure, because मेरे लिए life कभी रुकी ही नहीं थी. Like being in this field, of course, after the initial shock, I knew I was in safe hands. My oncologist is right here with me. I work with him.
Mine too.
So exactly. So for me, yes, the initial, I will not lie and say कि no, सब ठीक था. Initial, वो तो होता ही है सबके लिए.
Yeah.
But once I knew I had to go ahead. And वो रोना धोना मुझे, it was not going to help me.
Yeah.
So then I just took it in my stride. Obviously, again, being in the field, knowing the surgeon also, knowing everybody, made my life that much easier.
Yeah.
I just had to send my report to him on WhatsApp and he called back and said, don't worry, this is very early.
Yeah.
99% we won't need a mastectomy. So all that helped, definitely. And again, what I do, I actually preach. I mean, in the field that I am in, on care, which I run, is constantly telling people to be as active, as normal throughout the journey. So basically, I just practiced what I preach. I took it into my this thing. On the 6th day of my surgery, I was back to work. I had a conference to organize, so I was fully involved in that.
On the 12th day of my surgery, I was in Abu Dhabi.
So lovely. So that's how I think everybody should do it.
Yes.
Chemotherapy, yes, there were good days and bad. From the 3rd to the 10th day, I don't think I was in a position to move. I was really low, like low on energy, low on everything. Yeah. But you just kind of motor on. You kind of motor on. And like 8th, 9th, 10th day, I was back to work. So overall, for me personally, radiation, I think, was the most difficult because I landed up with a lot of dermatitis, a lot of burns. I had to actually halt the radiation because the burns got too severe. And they kept saying that we don't know why it's happened to you because you're not one of the prime candidates who should have, landed up with those things. Having said that, it happens. And for me, everything was कि ये short term है.
This is temporary.
जो भी है, it's temporary. And looking at the larger picture, looking at the long term, I had decided that whatever needs to be done, I will do it. And I actually did it. So getting back, today it's just a month post all my treatment. And I think I am, as I said, quite normal. And I think it's easy to do it for everybody.
You feel energetic, good.
As I said, it's a new normal. I mean, I was super energetic before. So I can't compare myself to the old me. Yeah. But I am taking, and I'm sure even that gradually as I work on my, exercise,
diet,
motive, all that whole routine, I'm pretty sure I will be back to normal.
Much better.
And like Dr. Advani rightly said, it's that initial phase of stress, the worry, like, will it recur? But once you kind of get used to it as life goes on as normal, then you kind of tend to forget about it and say, okay, this is all going to be fine.
So everything's going to be fine. And everything will be fine.
It will be fine. Yeah, exactly.
Thank you. Thank you so much, ma'am. So, sir, I have a question. How do you counsel patients about risk of recurrence?
Yeah, I think we tell them the truth that all of us live on the hope. And you have, as a physician or in charge of the patient, we have no right to take away the hope from the patient. I'm very clear about it. I tell everybody, all my colleagues know this, that don't use the word which takes away the hope from the patient. Never. It may be absolutely terminal phase. We have no right to take away the hope. Always say, yes, we are trying our best. we are with you. That
And
should
you
be
never
the,
know.
that's
You
right.
never
sir.
know. I know people जो अपनी will से जिंदा हैं.
Absolutely.
Genuinely, मतलब
Yeah.
उन पे कोई भी medicine काम नहीं किए, but वो will है जिंदा रहने की, और वो जिंदा है.
And of course, along with this, you emphasize on the facts about the diet, about the physical
Exercise.
activity. And the most important thing is ask them to live a normal life.
Normal life.
Go back to the work. Don't sit at home.
जी.
Many patients, they say, I've taken 6 months leave.
No.
I say, for what? Why you want to take 6?
I
Go
remember.
back to your work.
I remember in my while my chemotherapy was going on, he was the one who suggested कीमो के दिन भी कीमो लेके घर जाओ और 5 किलोमीटर वॉक करो हर दिन. So
Yes.
that's what he used to tell me always. So
Yeah.
I think that helps. That really helps.
It really
And it
helps.
did.
Yeah.
Thank you so much, sir. Sir, my question for you is, how does finding breast cancer early change the kind of support someone needs after treatment?
Now, as you know, early breast cancer, the number of modalities of treatment may be less.
Mm-hmm.
Just for example, if it's a very early stage disease and if you can skip chemotherapy, you just receive hormonotherapy and breast conservation, then only radiation.
Mm-hmm.
So the number of modalities will be reduced. The time required will also be less. So, and always we are aiming at a much more reasons of a cure for us. So obviously the counseling will be, as Dr. Advani said, much more favorable than unfavorable.
Ji.
And as it is, we always try to concentrate on the favorable things. Here it will be much more favorable, and the patients also, we can say much more confidently. There will be much more confidence in us also to counsel them that your treatment is over and here you have a chance of 80% cure or 90% cure, whatever our statistics says according to the stage of the disease.
Ji.
So the counseling will be much better, the patient will be much more relaxed, and it will be a much smoother process future on. Rather than a patient who has a third stage or a very advanced disease.
Ji.
It will be a totally
little
different story.
Different story, yeah.
You can tell. And you'll be much more confident in telling that story.
I agree, but then I think no matter what the stage is, your will and your confidence really, really makes a lot of difference. If you have that will to live, you'll fight it.
Absolutely. Nowadays, we have seen this fourth stage patients also leading a normal life. Absolutely, with the type of hormonal therapy and the newer advances, the immunotherapy, the newer advances have totally changed the outcome of the disease, which means I am in practice for last 30 years, so maybe there for 40 years.
Yeah.
But what we were there and what we were doing earlier, it's radically different, radically different. At that time when we were studying, we did not know also that these things would be happening. And still better things are going to come.
Better things are going to 5 years down the line. Yes, absolutely. Thank you so much, sir. Dr. Nadkarni, how do you determine if a patient is suitable for breast conserving surgery versus mastectomy?
Before I answer that question, I would like to make one statement that whether you do a conservative surgery or a mastectomy in a patient who has got an early cancer, the cure rate remains exactly the same. There is a general myth that exists that a mastectomy, because there is a greater amount of sacrifice or a bigger surgery that is done, more radical surgery that is done, that will give you a better cure rate as compared to a conservative surgery, and that is not true. So there are very clear-cut indications where one should do a mastectomy, and for all others, one should do a conservative surgery. So the patients who require mastectomy are patients who have multicentric disease. So they don't have only one lump in the breast, but they have multiple scattered lumps either as cancers or even precancers, microcalcifications that are distributed all throughout the substance of the breast. This is an absolute no-no for a conservation. Mastectomy is required. A person who presents to us with a locally advanced disease, so the patient has missed the disease and it has become a little big. In these cases, when there is skin involvement, we generally prefer to do a mastectomy and we avoid doing conservative surgeries. The third new addition to mastectomies, is BRCA positive patients or patients who are positive for a genetic mutation within them. These are those patients who have a genetic mutation within them which make them prone to getting recurrent cancers more and more. So these are the patients with whom we sit and we actually counsel them, not that these patients will get any adverse result out of doing a conservative surgery. They'll get a same effect or cure rate, but the risk of getting a second new cancer is going to be high.
It's a risk reduction, sir.
Correct, risk reduction. So these are the third one that we have added. The another soft indication is there are some situations where radiation therapy cannot be given to patients. When we do a breast conserving surgery, radiation is a part and parcel of treatment. And you would be inadequately treating the person if you were to do a conservation and not give radiation. So there are some health situations where you cannot give radiation to these patients. These are the patients we will choose for mastectomy. Rest all will be conservations. So conservation patients, localized disease, a small lump in the breast or a cluster of small tumors in one quadrant of the breast, you can safely do conservative surgery with oncoplastic surgeries today. So we have pushed the envelope now more and more and more. So in my clinical practice today, out of every 100 patients, 75 would be conservations, 25 for the reasons we discussed, we would do a mastectomy.
Depends on the nature of the disease and everything, and that's how you decide.
And also patient choice.
Also patient choices.
There are some patients who
do not
will
agree.
understand the whole thing and then they will say, doctor, I want a mastectomy. You have to respect that person's choice.
There will be patients who will say they want a mastectomy.
Correct. They will say, I have evaluated the pros and cons of both. I, for whatever reasons, do not want to take radiation therapy. I am 40 years of age, but I choose a mastectomy. Yes, they do. And you have to sit with them, counsel them. And if they do that, you have to respect what they want and you have to do it for them.
Their choice.
Absolutely.
Yeah, and there are also patients where mastectomy is a must, but they don't go for it.
Correct.
Especially in India.
Correct.
Considering
people stay in a remote area, where cannot get radiation.
We do a mastectomy.
Thank you, sir. Dr. Khurshid, how did you rebuild confidence in your body and mind after your diagnosis?
The body was definitely easier. Compared to the mind.
So,
So body, as I said, the hair loss. And, after that initial phase of, oh my God, my hair's gone, I was absolutely okay with it. I said, okay, this is to hell with it. This is my new look. This is the way I am. And of course, it helps when people tell you, oh, this is looking lovely and whatever. So that helps. Exercise, very important. Like, sir, if he told you, I was also regularly walking.
So was I.
I had never stopped walking. Like, however weak I felt, at least for half an hour, if not more, I continued to build my strength.
It really helps.
Yoga was another thing which tremendously helped me. Like the pranayams, just the breathing technique. So even the days when I couldn't really do any physical, like, the asanas and all, the pranayams definitely helped.
You did not stop the breath work.
I did not stop the breath work at all. I listened to my body. So that's the body part, I think, was easier than the mind. The mind, yet you have to work with it. I mean, and again, what helped me with the mind was the practice of mindfulness and the whole philosophy of mindfulness of, living in the present moment, enjoying today to the fullest, and not thinking too much about what's to come.
Something which you have no control over.
Precisely. But then it's a practice. You have to kind of develop it.
As I said, it comes after so many setbacks. You're like, leave it, I mean, just let it happen.
Exactly. And like, again, what Sir said, and hope, and I've been his student. He's been my first guru in the field of oncology. And Dr. Advani has always had this never say die attitude. I mean, even with our thesis work, he always said, it's going to happen. There's never a negative thing. So learning all these things, you just kind of try to imbibe it in your own life.
And it really helps.
And again, having said that, I mean, this is what you see patients, and you truly feel blessed, you feel you have really no reason to complain because you're just dealing with one aspect of the disease, which is just getting well. The kind of patients that we see, they have multiple other issues, from financial to social, people who've been abandoned. So you just bless yourself for where you are and, count your blessings.
Yeah, like I say that I wake up every day. The first thing in the morning I do is join my hands and in gratitude. Thank you for another day.
Absolutely.
Because people are going through so much.
Correct. So I think all that helps to kind of build a positive mindset. And you have to work on it. It's not easy.
It's not easy.
There are times when I'll yet go into this thing and what if, and those doubts start creeping in. but you have to kind of
I
try
think
to
that's
push it
natural.
out. Yeah,
Yeah.
yeah. But it's again, as I said, it's work in progress, and you have to try to keep working at it, and trying to be as positive as you can.
Thank you, thank you, thank you so much. आपके इतने इंसाइटफुल बातों के लिए अब हम बात करेंगे कि कैसे फैमिली और पीयर सपोर्ट पेशेंट्स के लिए हिम्मत और बैलेंस का सॉस बन सकते हैं और लॉन्ग टर्म साइड इफेक्ट्स कैसे मैनेज किए जाते हैं. तो सर, सबसे पहले मेरा सवाल आपसे है, हाउ कैन फैमिलीज बेस्ट सपोर्ट एंड ब्रेस्ट कैंसर पेशेंट इमोशनली एंड प्रैक्टिकली?
जैसे अभी डिस्कस किया कि बॉडी को कंट्रोल तो इजी होता है, और माइंड को कंट्रोल डिफिकल्ट होता है. और मतलब दैट डिपेंड्स अपॉन योरसेल्फ आल्सो, पेशेंट.
जी.
तो धीरे धीरे वो सीख जाते हैं. और ये सब माइंड को चेंज करने के लिए बहुत कुछ सपोर्ट की ज़रूरत है. हमारे हिसाब से जो बेस्ट सपोर्ट मिलता है, दैट यू कंटिन्यू वर्किंग, continue whatever you are doing before. So you really then you feel you are normal as before.
Yeah.
So why worry?
Yeah.
So I think that is the most important thing. Workplace, work friends. Second is the family, your parents or the brothers,
Your
sisters,
husband, your
or
wife.
everybody around you. They play a very important role. And I will not say that you need sympathy. You don't need sympathy. Nobody needs sympathy.
Gee.
The moment many people dislike sympathy.
Yeah.
They dislike sympathy, or patience, I think. But they require interaction as a normal person. So the moment the relatives and everybody understand that we have to also live as a normal person as before, it becomes heaven for the patient.
Starts
So I think
behaving with them normally.
That's right.
Yeah.
And once you practice this thing, everybody around you become also positive.
Positive.
So it's that you have to turn the environment positive for you.
Gee.
So you have turned that. It's not that other people will come and turn your environment.
Turn it for you.
Never. But it's yourself. So you turn everybody positive about it. Whenever the patient comes, I always tell them, he says that, how am I going to live? I say, you have seen my OPD around? There are 30, 40 patients sitting outside. Did you see anybody weeping over there? Patient?
Cancer makes you stronger.
Yes.
Yeah.
I think that's clearly so.
Yeah.
They get so much of the strength.
Yeah.
It's the God which gives them the strength, to go through the whole treatment.
Yeah.
And I must say the treatment is not simple.
Gee.
It's heavy for some of them. But then if you are strong, you have a strength, and your support system in terms of the family members, friends, and workplace, if everything is good, you go through it.
You sail through it.
Yeah.
Thank you, sir. Thank you so much. Dr. Boman, my next question is for you. What long-term side effects should patients be aware of following cancer treatment, particularly when the disease is detected early?
As I told you in my last answer only, if the disease is detected early, the number of modalities of treatment may be less.
Okay.
Number of modalities. You know the modalities of treatment.
Gee.
Chemotherapy, surgery, radiation, immunotherapy, all these are different modalities.
Some may don't need chemotherapy also.
Yeah, absolutely right. So the number of the modalities are less, obviously long-term problems are less. But there are some problems even an early stage patient may face. Many times in my OPD when I see patients, many of them would come with few things. If they have received chemotherapy and they have received platinum group of drug, that neuropathy which lasts for a very long period. So patients are cured, but they'll say, sir, when is this going to go?
Yeah, it doesn't go.
So you have to tell them, this will go, it will take time, it will take time. The positive attitude. And what is that? Ultimately, so we have to tell the positive part, it will go, but it will take time.
Yeah.
So the common thing that we see is this neuropathy.
Yeah.
Operated side, with all respect to our surgeons, the operated sides, that scar and that numbness feeling.
Yes.
The numbness feeling which the surgeon gives, we give them neuropathy. If they have received some cardiotoxic drugs, the long-term toxicity is cardiomyopathy. But generally, in early stage patients nowadays, we avoid anthracycline group, the drugs which produce cardiomyopathy, which is not usually given. EC, yeah.
Right.
Yeah. So long-term toxicities are there. neuropathy is such a thing which is unpredictable. After completion also patients have got, unfortunately. We try to stop. And nowadays there are a lot of things by which we avoid neuropathy also. Cold compresses, but still some people do get.
Yeah.
Hair loss is temporary, as you
Yes,
all of
it's
you know.
all temporary.
It's all
Yeah.
temporary.
Even this pain
So
will go.
long term, So long term toxicity are generally those few which are innocuous but troubling the patient.
Yeah, and the intensity reduces.
Yeah,
like,
over time.
like
So
anything.
they may be innocuous, but it is troubling the
It
patient.
is troubling. It
That
wakes
is
you
what
up at
you
night.
have to tell them. That this is innocuous. It will trouble you.
One thing which he's missed, if I can add, which especially
Sure,
for breast
sure, please,
women,
ma'am.
is lymphedema.
Yes.
It's
Lymphedema.
again
Yes,
something
sorry.
which surgeons very often say, it's okay, it's,
Again, tell me about
it's
it.
a nuisance value, but I mean, I'm telling you, at any given point of time in my center, I'm treating at least 4 to 5 women with lymphedema. Also, which is very avoidable, I think, because if the exercise routine is continuously done, the lymphatic
It
drainage
goes down.
But the counseling is, I'm sorry, it's very often not done enough. So people will maybe be on that routine for about a year, 2 years, and then they feel, okay, everything is fine. So, they kind of forget. So when you're talking of long-term side effects, this is one of the most common
Common side
especially in breast cancers that we have seen. And once it starts, it's very difficult to take care of. So we have the lymphopress, we do manual drainage for them, we teach them, we give them sleeves. But again, nuisance value, not life-threatening, but definitely something that, affects the quality of life.
And
So, please.
early stage disease, if they have not received radiation and an extensive surgery, lymphedema is usually not there. But of course, if extensive surgery, radiation...
And multiple nodes are off.
Then
If I could add here, yes, lymphedema is a known sequel of our treatment. I would not call it complication because beyond a limit, it's out of our hands. But once upon a time, the surgery for breast cancer meant you have to take the lump out or the breast out and take out all the nodes from the armpit. And when you did that, for every 100 women you operated, 30 would get lymphedema. So if 20 years ago, I was sitting in an outpatient clinic in the breast department of any hospital, 1 out of 3 patients would have had mild to severe lymphedema because that was the ratio. Now we have something called as sentinel lymph node biopsy, where we are able to identify those patients where the cancer has not spread to the lymph nodes and avoid a complete axillary surgery, so they don't get lymphedema. In patients who have only 1 or 2 lymph nodes that are involved, you have 3 clinical trials new. I won't go into details, but they say you don't have to complete axillary dissection, just cover with radiation. Only those patients who present to us with multiple nodes positive, we do not yet have a medically safe solution. Clinical trials are going on, except for doing a lymphatic venous reconstruction. If you know, we did that in you. We did microscopic with 10-0 sutures.
His best.
Okay, but still that reduces your lymphedema rate from 30% to 6 to 10%. It doesn't become zero. So what God gives us, unfortunately, when you touch it, somewhere you have a bit of shortcomings, and you will see a few patients with lymphedema. Hopefully, as science advances, we are going to get lesser and lesser patients. But today, as I said, in my OPD, less than 5% of patients will have lymphedema. So that's a big difference in my lifetime I've seen, and I've practiced only for 22 years.
And how do you define lymphedema? Like how big is the arm from the other one?
So if you have a width of the circumference which is more than 2 centimeters as compared to the opposite side on the arm, then you have a lymphedema. But somebody may have a small lymphedema but may be bothered. Somebody may have a large lymphedema but may not be bothered. So lymphedema in general is something that is not something you like in your patient, absolutely. But those patients in whom it affects their day-to-day activity are the patients who bother us more. I can imagine if there is an ophthalmic surgeon, her hand needs to be so super precise, and if I give her a lymphedema, I mean, I don't give it. But if I operate and she gets a lymphedema, it bothers me like hell. Okay, not that the other women don't, but here is like your day-to-day existence is at stake.
Is dependent on your hands and your...
Correct. That is the reason so many advances today. That is the reason we have come down from 1 in 3 to 1 in 20 lymphedemas today. And we are going to get better.
The next question is to you only, sir. How much role has robotics played in breast cancer surgery?
So robotics is now making its inroads for breast cancer surgery. At the moment, the role is limited. Robotics for conservative surgery, nobody is really using robotics. Robotics is useful today mainly in patients who are undergoing bilateral mastectomies or mastectomies with reconstruction.
Really?
Yeah, where you make a cut on one side, okay, and then you do a bit of the dissection just like you do a normal dissection, and then the dissection that is done on the inner aspect of the breast, it's done using a robot. Okay, so the advantage is that the scars don't remain on the breast, they tend to go a little further away on the sides, so it becomes more or less like a scarless surgery. But you need to choose your patients for this, okay? It is very, very, very aggressively done in countries more towards the Southeast Asia. A woman who has a smaller size breast, okay, is very well suitable because this is a patient where you do not need any reduction in size. So you just have to take it up and put a proper implant of the
Bigger one,
same
yeah.
size. But in countries where the average size of the breast may be bigger and you may need to do some skin reducing surgeries to be able to give a good cosmetic outcome, this technology is going to be found wanting at the moment. But yes, it's making its inroads in a limited way. And, the next few years will tell us how we adopt it.
So, Dr. Khurshid, my next question is for you. What role did support groups, friends, or community play in your journey?
I think it was huge, absolutely. Especially family, colleagues, as Sir said, like at work. And for me, knowing this particular family was like a humongous support system. I didn't have to worry. I didn't have to second guess anything. So it is important. It is extremely important. So support groups, if they are restricted to emotional support, that kind of thing, it's fantastic. But when people start exchanging notes about their treatment protocols, then it's a little scary. Family, friends, huge support. I mean, I don't think any of us can, navigate this journey without that.
Our family and friends.
I mean, and like Sir again said, we don't realize the burden on them. Like even my husband, for example, my son,
always say,
who was abroad, like, he was so many miles away. And I tried to keep things away from him, thinking I should not worry him. And that made matters even worse. So this collusion again, is, I think, we always say not to have it, but I again started doing it in my own case, where I first thought I would not let my mom know, I would not let my son know. But it doesn't work. To get their support is very important.
Very important.
And to support them in turn. Like, I mean, for you to be positive, when they see you leading a normal life, going back to work, I think for them, it's very reassuring also. So I don't think you can navigate this journey without some support, whether it's friends, whether it's... And again, you feel truly blessed to have that kind of support, because in our clinics, very often we see patients coming in alone, where they don't have big families, or, either people are abroad or the elderly family and, kids are settled abroad. So it is it would be very difficult for that. So support, very, very important.
Very important. I often say, patients se zyada difficult or terrible journey caregiver ki hoti hai.
Absolutely. Absolutely.
Thank you, ma'am. Thank you. Sir, how do you handle survivorship in young women balancing careers and families?
Yeah, young people have a lot of aspiration. They want to grow bigger. That's where they go into the trouble, because they want to see they finish their education, they should get a good job, they should reach to a certain level in the life, and also get married. So all these things are the big thing. And therefore, slowly you have to tell them that even with all this treatment and the disease, you can live a normal life. I think that reassurance make a big difference, and support them. But I must say that we must talk truth to them. I think that's a very important thing. And that is also going to be helpful for them. Like for the young ladies, where we feel that they are going to be cured of the disease, the chances of cure are, we tell them that what about your reproductive function, how you can preserve the reproductive function.
Yeah. Thank you, sir. इस बात से हमें ये समझ आया कि यंग पेशेंट्स के लिए करियर और फैमिली बैलेंस करना और मेंटल हेल्थ मेंटेन करना कितना चैलेंजिंग हो सकता है। और इसी बात पे डॉक्टर बमन, आई वांट टू थ्रो दिस क्वेश्चन एट यू. How have advancements in early detection and prognostic tools influenced surgical decision making in breast cancer, particularly in minimizing the need for chemotherapy?
Yeah. So first thing, as Dr. Khurshid said, breast cancer is not one disease. It's a different stages of the disease. The character of the tumors are also different. So apart from being in an early stage, you may have a bad character of the disease. So character is different. That is how this disease is going to behave. Is roughly what we say as the character of the disease or the molecular features of that disease.
Okay.
So what is now important is not only the stage of the disease. Like, just to give you an example, early stage disease can have poor molecular characteristics. Or advanced stage disease may have a good molecular characteristics. So from this, how do we define that? Molecular characteristics are now studied in a different manner. Now, genomic analysis tells us how this tumor is going to behave. And we have multiple tests in that for a very early stage disease, where there is ER and estrogen receptor, progesterone receptor positive disease. And nodes are negative. It's a very early stage disease. So we know this disease is very early. Do we give chemo or we don't give chemo? There is always this is one of the most debatable thing in oncology. So do we give, if the nodes are negative, just ER/PR positive? So what I would do is, in these patients, I would try to do a genomic analysis. And from this genomic analysis, you can understand the molecular characteristics of the tumor. If the scores are high, that means yes, this patient is suitable for chemo, we should give him, because although it's an early stage disease, this disease may behave badly. And these tests are many times validated in thousands of patients. And then they come out, they are correct in the tune of 90-95%. When they say recurrence score high, you treat it. When the recurrence scores are low, wait and watch.
This is for hormone positive patients?
This is for hormone positive patients. And HER2 negative, because what we believe that HER2 positive patients are always aggressive and they require anti-HER2 therapy, unless the tumor size is say less than 0.5 centimeters. Then it's a different story. But all HER2 positive patients require nowadays treatment. So we don't include that only now.
Thank you, sir. Thank you. Thank you, sir.
So if I can just add what I tell my patients, okay, to try and make them understand the same thing is, पेशेंट आता है सामने, कहता है डॉक्टर साहब आपने तो ऑपरेशन के पहले बोला था ER/PR पॉजिटिव अच्छी बीमारी है, अभी आप बोल रहे हो कि मैं श्योर नहीं हूँ इसमें कीमो की जरूरत है कि नहीं। इतने सालों का डेटा हमारे पास अभी अवेलेबल है जो कहता है कि शायद बहुत सालों से हम पेशेंट्स को ओवर ट्रीट कर रहे थे कीमोथेरेपी से जो हार्मोन रिसेप्टर पॉजिटिव थे। और ये टेस्ट जो अभी हमारे पास आई है, ये टेस्ट हमारे लिए एक सुपर बून है, जिसकी वजह से हमको एक्चुअली समझ में आता है किस पेशेंट को कीमो करना जरूरी है और किस पेशेंट को बगैर कीमो हम क्योर कर सकते हैं। सो इट इज प्रिसिशन मेडिसिन दैट वी कैन फॉलो।
एक जमाने में खाली नोड नेगेटिव था, मैं अभी नोड पॉजिटिव पेशेंट में भी टू सम एक्सटेंट इट हेल्प्स।
इट्स एक्साइटिंग एंड वी आर गेटिंग देयर। lesser treatment, better and better outcomes.
Better outcomes. Dr. Mistry, what message of strength and hope would you give to other survivors and families?
So the first thing is, don't be scared of the word cancer. I think वो नाम सुन के ही people start getting scared. So I think that's the very first message.
Yeah.
Don't shy away from screening tests. And the message that Zydus is spreading right now,
Yeah.
2 Haath 3 minute, I
Yes,
think is a
yes.
very, very important message. I detected my lump
mine
with
too.
my self-examination. So I think it's because see, you can go for screening, you can do a sonography, mammography every 6 months, once a year. This you can do once a month, and I think it's an extremely important screening tool. Just examine yourself in the right
3 minutes.
in the right way.
Yeah.
Right? That's the first thing. So first message. Second message is, don't be scared of the treatment protocols like chemotherapy. I have so many patients saying, हम लोग कैंसर से मर जाना प्रेफर करेंगे लेकिन कीमोथेरेपी नहीं लेंगे. So that's the other thing, that even with chemotherapy there are so many advancements. We have superb supportive medicines now, you know, so even for nausea, for loose motions, whatever the side effects of chemotherapy are so beautifully managed with the new generation of drugs. So do not be scared of any therapy, like any kind of treatment. If required, please go for it. And lastly, trust your doctor.
Yeah.
Trust your doctor, because it's the age of Google, it's the age of AI. People are going to go to it. And to the doctors, I would say, please accept it. You know, so in the sense, patient information is important, the autonomy and the right for the patient to know what they are going through. But I think it would be better if the doctors gave it to them rather than them trying to Google it and listening. So trust your doctor. Choose one.
Yeah.
You can shop around, you can get opinions. But once you have selected your doctor, have faith and trust in that person and follow the treatment.
Yeah, but then somewhere destiny also plays a very,
of course
very,
it does.
very
Of course
important
it does. So, you know, this
no matter how hard you work, no matter what you do.
Correct.
I think in cancer, destiny also plays
of course.
a part.
Like in life.
Yeah,
in
like
everything in life.
So we should just let it be. Just sail through it.
Completely.
Thank you so much, everyone. ये सुनकर लगता है कि हर वॉरियर का सफर कितना अलग है. उनके चैलेंजेस, उनका डर, उनके इमोशंस. मैं खुद इस राह से गुजरी हूँ और जानती हूँ कि डायग्नोसिस का पहला पल कितना अकेला और ओवरवेलमिंग लगता है. कभी ऐसा लगता है कि सब कुछ रुक गया है और हर तरफ बस डर ही डर दिखता है. लेकिन मैं ये भी जानती हूँ कि हर औरत के अंदर वो ताकत होती है जो दिखती नहीं है पर होती है. वो ताकत आती है उम्मीद से. उम्मीद की रोशनी से हम अपने डर को छोटा कर सकते हैं, ट्रीटमेंट के हर स्टेप को हैंडल कर सकते हैं और अपनी जिंदगी को वापस जी सकते हैं. आज की बातचीत सिर्फ कहानियां नहीं थी, ये उम्मीद के सबूत थे. डॉक्टर मिस्त्री, थैंक यू सो मच फॉर योर टाइम. आपकी स्टोरी बहुत ज़्यादा इंस्पिरेशनल थी और आपकी स्टोरी से उन हज़ारों औरतों को बहुत ज़्यादा हिम्मत मिलेगी जो डर में और शक में जीती हैं. एंड आई एम टेकिंग बैक अ लॉट ऑफ स्ट्रेंथ फ्रॉम यू. थैंक यू सो मच फॉर बीइंग हियर. और मेरे जो एक्सपर्ट ऑन्कोलॉजिस्ट हैं उनका भी मैं धन्यवाद करना चाहती हूँ, जिन्होंने हमेशा की तरह हमें फैक्ट्स और क्लैरिटी दी. ये याद दिलाने के लिए कि एक छोटी सी आदत, सिर्फ 2 हाथ 3 मिनट, एक आसान सा एग्जाम, ऐसी जांच है जो आपकी जान बचा सकती है. मैं हिना खान आपसे यही कहूंगी, अपनी सेहत की जिम्मेदारी लीजिए. अपने 2 हाथों से 3 मिनट में लीजिए एक सबसे आसान पर सबसे जरूरी एग्जाम.